It's now my honor to introduce Dr. Altmiller. And Jerry has been with us. She joined us right after I came on board. I came on board in July, and she came in January. So you have come up your 2 years now of being part of TCNJ. She is, as she said, the associate professor here at the College of New Jersey and in the School of Nursing, Health, and Exercise Science. She still maintains her clinical practice as a clinical nurse specialist at Einstein in Philadelphia. She also is very active in terms of consultation with nurses about nursing research and evidence-based practice. She's been a member of the Quality and Safety Collaborative for the CUSIN Collaborative since 2006, and she has served as a member of one of the pilot schools for that work. She's currently a national consultant for CUSIN, providing workshops such as this from around the country, and serves on the CUSIN Institute Advisory Board, is a director of now the CUSIN Institute Regional Center here at the College of New Jersey, which she will talk a little bit more about that evolution or revolution. And she was invited by the National Councils of State Boards of Nursing to develop teamwork and communication module of their Transition to Practice program designed to support nurse residencies for the new to practice nurses. She's a Lindback Award recipient for Distinguished Teaching in 2014, and she has published extensively about quality and safety in graduate and undergraduate nursing education. She also encourages our students to create, and has created, a newsletter, a CUSIN newsletter, that they are the living experiment in terms of CUSIN, to bring what they learn in the classroom and the clinical to a newsletter that's published on our website. Her research is focused on communication challenges as well as incivility in the educational and practice environment and the negative effects these impose on patient safety. Dr. Altmiller.
Thank you. So today we are going to start out by doing an introduction talking about CUSIN, and then our guests are going to build on that, going a little bit deeper into some of these concepts that I'm going to share with you. I am a nurse educator, so everything that I'm going to share with you is about how you share it with other people, and we're going to basically throw ideas at you all day long that you can implement into your classroom activities or into your orientations for new nurses or into your ongoing education for nurses in practice. Anything that you see here today is either on the CUSIN website where you can download it for free and use it, or you can get it from one of us by emailing us. I want to tell you that anything that you use off the CUSIN website, you are allowed to make adjustments to. The only caveat is that you make some kind of notation about the author who created it, like courtesy of such and such a person, but you certainly can change things so that they fit into your work. So let me start by telling you I have no conflict of interest today in this presentation. To give you a brief overview of CUSIN, what I will tell you about it is that we all know about To Err Is Human, and we know that the IOM followed that up with core competencies that all healthcare professionals should have. So what happened around 2005, a group of health professions educators, which were mostly nurses, formed a collaboration, which was the Quality and Safety Education for Nurses Collaboration. They were well funded by Robert Wood Johnson. They created competencies that would change the way that nurses were educated, to move from being a task-oriented role to being this role that was about knowledge, skills, and attitudes that are focused on safety, that are focused on quality improvement. So CUSIN developed 6 core competencies. They added safety as the 6th item. In the 11 years that this has been going on, CUSIN has had multiple phases. There was a phase where they brought on 15 pilot schools to create teaching strategies and share them nationally, and that's what you see on the website, although now more teaching strategies are up there as people are doing them and sharing them. It's a great place to publish your ideas and your work. There was a phase 3 where AACN was part of that, and they disseminated it in train-the-trainer sessions. There was a phase 4 where they brought it into graduate level and made core competencies for the graduate nursing student. Where does all this lead to? What is the relevance? It is relevant to nursing education and practice in a lot of ways. Anybody who's in an accredited school, ACEN, uses it as part of their accreditation criteria. AACN uses it as part of their accreditation criteria. It is part of the baccalaureate essentials. It is part of the master's essentials. It is used in all transition to practice programs. So it has become relevant to practice and to academia. So to people who think that CUSIN is only about education, I'm going to tell you, no, it is not. So a young man named Giancarlo Lyle Eldrizzolo out at University of San Francisco was doing a DNP project, and he crosswalked the CUSIN competencies with the Joint Commission standards with the magnet standards, and he found that everything flowed beautifully together and everything fit together. So the idea is that CUSIN should be part of all undergraduate or pre-licensure nursing education, and then it should flow seamlessly through into practice because it brings that person into the practice setting ready to do all the things that they need to do to meet the Joint Commission standards and to meet magnet standards. So with all of that in mind today, our objectives are to identify knowledge, skills, and attitudes that emphasize the CUSIN competencies, to demonstrate strategies that can be integrated into classroom and clinical teaching to support behaviors consistent with the CUSIN competencies, and to discuss resources to support educational and implementation strategies aimed in quality improvement, patient safety, and systems effectiveness. So we're going to start off with patient-centered care. That is the first CUSIN competency. With that competency, the patient is in control and a full partner. Care is based on respect for patient preferences, values, and needs. So what does that mean? That's really about thinking about the patient and letting them be in charge of their care, promoting self-efficacy instead of us telling them how it's going to be, asking them, how do you want it to be? Really individualizing care in a way that we have never done before. So some of the things that I would like to show you out on the web, Barry, if you can take us out there, the Picker Institute. This is a great little site that is completely focused on patient-centered care. Picker principles, there's 8 different principles of patient-centered care. They show you different ideas. You can take your colleagues out there or your students out there and show them these 8 principles. The principles are explained and then they are shown in short little Vimeos that you can embed into your presentations. So to talk a little bit about that, each of the Vimeos shows the presentation has an example of it. Like the first Picker principle is respect. With respect, you see a woman come on and she talks about how a doctor will walk into a room and he'll say, "Hi, Pearl, I'm Dr. Smith." So the idea is that he is okay with being on a first-name basis with the patient, but the patient is not on a first-name basis with the doctor, no matter who they are. And that really takes us out of that level playing field. So we really need to get away from that and treat people with respect when we walk into a room. "Hello, Mrs. Smith. I am Dr. Jones." That idea. So it really emphasizes the principle to our students not to call their patients by their first name and to address them by their titles. Another site that I wanted to show you is the Institute for Patient and Family-Centered Care. That is a website that's really about patient-centeredness, but has tons of resources. Whenever you go to one of these resources that I'm showing you, the website, go across the top, click on resources, and all of them have a site called free downloads. On the patient and centered care site, when you go to free downloads, down pops a list of about 20 different items that you can implement in your classroom and your orientation to help people focus on patient-centered care. The idea is that it gives you ways to bring it into discussion. You can take it into post-conference. There's a piece on there called a patient centered care assessment. It's a great tool for a student to think, do I really do these things? Like it asks questions. When patients talk, do I actually listen, or am I thinking about the next thing that I have to do? I know as a teacher, a lot of times, that's what happens with me. I'm hearing them, but really thinking, I got this, I got that. So it's really about bringing your consciousness into thinking about patient-centeredness all the time. So one of the best resources that you can use is IHI's Open School. I don't know how many of you have heard about that, but that is a free resource if you are a faculty member or if you are a student. What that is really excellent modules that teach about quality and safety. They're interactive. When you do a module, it's about an hour and a half. Each one has 3 or so lessons. At the end of the 20-minute lesson, you would take a test. You need to get an 80% on before you can progress. It's interactive, and you blog all through it, so it's a great opportunity to learn. When it's done, after you've done the module, you earn ANCC-approved contact hours for it, 1.5 for each module. You get to print a certificate, it goes into your portfolio. For you as faculty, it is a great way to learn the language of safety. We have all been teaching quality and safety for so many years, but the language has changed and the way that we approach it has changed. And so for us to refamiliarize ourselves with how we are doing it in this day and age, these are a great way for us to learn, and we can put them toward our requirement for our licensure. For our students, it is a great way for them to learn. It is better than anything I could ever present in a class. Now, for a basic certificate, there's 13 modules that can be completed. So here at our school, we have taken those 13 modules and spread them across our curriculum in different courses. So every course, a student knows that they are going to be doing one of the IHI modules to earn the basic certificate. When they graduate, not only do they finish their nursing program, but they have this quality and safety certificate that they graduate with. We have already seen the benefits of it. Our students are telling us that employers are very impressed that they're having them done, asking them, why did you do them? Faculty. So what I'm not going to go out to this site. This is something that you can do on your own, but I do want to show you a couple of things. So you go to IHI. See at the top here where it says log on and register? You would go in and register yourself as a professor, all right? It's free if you are a professor. If you register as an RN, there's going to be a fee that comes with it. Well, then when you put it in your classrooms, you tell your students to register as a student, and it will be free for them. Now, you can pay to track it online. I don't do that because it's one more job for me. What I have my students do is when they finish the module, they save the certificate, and I have them drop it into my Canvas, and I just check off that they all have it done, so it's easy for me. How to find it? Very simple. You're on the IHI page, you pick education, go to Open School, on campus, and the modules pop up for you. So this is a great resource that you can use. There are many more modules than the 13 that are in the basic certificate, but you can pick and choose how you want to do that. We made a decision as a faculty here at TCNJ that the basic certificate would be a good resource for our students. So when we think about patient-centeredness, we really want to help people to keep their eye focused on the patient. It's all about the patient. So things that we see happening in hospitals, whiteboards for patient goals. So every day the patient puts what's important to them up there, and even if the patient writes, "Get the hell out of here today," that's their goal, then let's go with it. And we need to be respectful of that. And I tell my students, whatever they put up there, that's the priority. Go with that. We need to get our students involved in helping the patient. When they go in and introduce themselves, what's your goal for the day? Let me put this up on the board for you. We have to think about value-added nursing. These are the things that make better value for the patient. Like rounding is value-added nursing because people get together and they talk about the patient, and we discover problems and we brainstorm. We have to teach our students to look at the non-value-added nursing and work to get rid of that, like waiting for delays, looking for supplies. All of these things waste so much time that we could be with the patient. So those are the things that our students have to be focused on. Let's get rid of that. Let's remedy that. And then, of course, we have to streamline the necessary but non-value-added nursing things like getting medications together and documenting. We have to do those things, but let's streamline it and make it easy. So let's go out to this site right now, Barry. This is Don Berwick, and he does a very good job of describing what it means to be patient-centered. If you can scroll down on this page, keep coming down. Here he is, Don Berwick.
I fear to be a patient. Partly that fear comes from what I know about technical hazards and the lack of reliability in care. Today I have a bone-on-bone pain and osteoarthritis in my right knee. I can no longer jog, which was my passion, or even run 4 steps because I had an unnecessary and now fully discredited knee operation as a medical student, an operation that had never been subjected to proper evaluation for a condition that had never been subjected to a hands-off arm of a clinical trial. My best friend had a severe post-operative complication from a drug dosing error at transition. It almost killed him. My research on errors in care show these errors to be terrifyingly the norm. But the honest truth for me is that the errors and unreliability of healthcare are not the main reason that I fear that inevitable day on which I will become a patient. For in fighting those enemies, errors and unreliability, I am aligned with the good hearts and the fine skills of my technical caregivers. I can use my own wit to stand guard against them. What chills my bones is indignity. It is the loss of influence on what happens to me. It is the image of myself in a hospital gown, homogenized, anonymous, powerless, no longer myself. It is the sound of a young nurse calling me Donald, which is a name I never use. It's Don. Or for her, maybe it's Dr. Berwick. It is the voice of the doctor saying, we think, instead of I think, and thereby placing that small verbal wedge, the pronoun we, between himself as a person and myself as a person. It is the clerk who tells my wife or my son to leave my room, or me to leave their room, without asking if we want to be apart. A close friend called a clinic for her mammogram report, and she was told, you have to come here. We don't give that information out on the phone. She said, it's okay, you can tell me on the phone. And they said, no, we can't do that. Of course they can do that. They choose not to do that. And their choice trumps her choice, period. That's what scares me. It scares me to be made helpless before my time, to be made ignorant when I want to know, to be made to sit when I wish to stand, or to be alone when I need to hold my wife's hand, or to eat what I do not wish to eat, or to be named what I do not wish to be named, or to be told when I wish to be asked, or to be awoken when I wish to sleep. You can call it patient-centeredness if you choose, but I suggest to you this is the core. It is that property of care that welcomes me to assert my humanity and my individuality and my uniqueness. And if we be healers, then I suggest to you that that is not a route to the point. It is the point.
So he does a very good job of describing that. I show that in my Introduction to Nursing class. It is our first level of them being introduced to the idea that they need to be a lifelong learner. And I think that's an important concept for them to get right away, that it's all about respecting patients' dignity. So some things that I try to make students think about is seeing through the patient's eyes, to always look for feedback and think about how does it feel to be a patient. Now I'm going to save some time here. This link here is to The Immigrant. It is a 6-minute Vimeo, really well done, that describes a situation where a medical error was made for a patient. The medical error was made because the patient's family speaks Spanish, and for some reason they disregarded their ability to describe what they needed because of their speaking Spanish instead of speaking English. The Vimeo does a great job where the one patient says, just because I speak another language doesn't mean I'm an alien from outer space. I still live and take care of myself and can think. And I think that a lot of people have that bias. And it's important for our students to think right away that just because people are different from you doesn't mean that they're not smart and can't take care of themselves. So it's a beautiful little Vimeo that you can access out on YouTube. I do want to tell you that every link that I'm showing you today is on that listing that's in your packet, so you'll be able to find these resources. But we'll skip this one just to save a little time and catch up here. The whole idea is that you want to teach your student to build relationships, solve problems at the point of care, involve the patient in everything you do. And some of the ways that we're doing that is situational awareness, knowing everything that's going on in the unit instead of just knowing what's going on with your patient, and thinking about rapid response teams, which are only useful if the people who come to the rapid response are supportive instead of condescending. I had a student tell me a story. No, I'm dead serious. I had a student tell me a story, works as a nurse aide, said she was up on the floor. The patient was having a lot of trouble breathing. She went out and told the nurse, and the nurse said, I'm not calling a rapid response. The last time the resident ridiculed me. And the woman continued to have trouble, so she called her husband, who was an ICU nurse, and told him, and he said, go in the room and I'll come up to visit you. And that's what they did, and he came up to visit, and he went out and he told the nurses at the station, you should call a rapid response, that patient's having trouble, and the patient was transferred down to ICU. Like, that's not the way it was meant to be. It's really meant to be you show up at a rapid response and say, what can I do to help you? Not, why are you calling me? What do you need now? So we really need to impress upon people that whole idea of rapid response. Someday you're going to be the person answering that rapid response. You need to come with a what can I do for you attitude. Personal accountability, thinking about reducing admission. The only way to do that is to make sure as people go out the door, they're ready to be going out the door. Medication reconciliation. This is huge. This is a big part of the patient safety goals. We need to make sure that our students have a very good understanding of it. So something that you can do, there is an exercise up on the CUSUM website called Medication Reconciliation Exercise. It was created by Pam Ironside and her gang out at Indiana University. And I use it in every semester in my med-surg class, and we do a med reconciliation on the first day of class so that students understand what it is. And it's an unfolding case, which is a great strategy for you to teach with. So I dropped it into here this morning just so I could show you these slides so you could get an idea. An unfolding case is where you introduce a patient to your students, and then you follow that patient through, and they have to make decisions along the way to learn how to take care of that patient. So this unfolding case actually works with students because it's got a little bit of drugs and a little bit of alcohol and a little bit of sex in it. So all of those things help them all to stay tuned in. So how this works out, and we're not going to run through the whole thing, but I'm just going to tell you it's a gentleman who had heart failure, comes in having trouble breathing, and as the nurse goes on to find out more, he takes something that starts with an L, and they get excited, oh, that's Lasix, and he takes digoxin and meta something, and they're excited because they know that's metoprolol, and they can talk about all this stuff, and thank God he takes a Moldavite. Like, we laugh the whole time through, and then we get to the crux of the problem. He's not telling you anything, and he doesn't know anything. And what they come to discover is he needs serious patient education. And we talk about, well, how are you going to find all this stuff out? And then we find out more about him, that he drinks occasionally, one drink at lunch, two after work, and one before bed. And oh, by the way, he uses cocaine sometimes. And then he borrowed Viagra from his buddy. And people know people borrow Viagra from their buddy. So on we go, and they put it all together to understand that he went into heart failure. What are you worried about? And what do we know? And we run through it. And this is how it all works. And in the end, we see Bob, nice, normal-looking guy, right? But somebody who really needed a med reconciliation because he had a lot of stuff ordered and really had a lack of knowledge. Then to carry that over, you know how you do clinical paperwork for your students, that they have to do things each week with their patient to write out, information to learn it. Well, most of us have them list their meds and do the classic, classification, mode, rationale for this patient. Well, I go one step forward. Their med list is actually a med reconciliation. So at the very bottom, it says, who did you talk to? And when did you talk to them? Now, I'm careful to tell them, don't ever put the patient's name in there, but you're going to put, I talked to the patient at 12:15 on this day, or I talked to the patient's daughter. But this makes them have to have a conversation with the patient or somebody who's caring for the patient about the meds. So it's taking something we've always done, but just putting a new twist on it so that they learn this new important patient safety aspect. All right, so this is a wonderful movie. This is Escape Fire. Has anybody seen this? This is an awesome video, and I show this in my senior nursing class. You have to put it further back so that people have some kind of experience in the clinical setting. This is a great video. I bought it for $14 on Amazon. It's really a beautiful look at our healthcare system. But after I was here, I didn't want to show it in class, so I asked the librarian to buy it, and for $300, they were able to buy the streaming rights for it. So now I have embedded it into my Canvas. If you have Canvas, Blackboard, Moodle, whatever it is you use, you can embed it in there. I assign it to my students as a work-at-home day, which they enjoy because then they can do class on their own time frame for one day out of the semester. They watch the video. The question that I ask them is, what are you going to do tomorrow? And all of them have to post on the discussion board. So if you can cue that up and run this, we're just going to watch the trailer.
The American healthcare system is badly broken.
The present system doesn't work, and it's going to take us down. We need a whole new kind of medicine.
We're in the grip of a very big industry, and it doesn't want to stop making money.
If I spend 5 minutes with you and then put in one of these stents, I probably get paid $1,500. For me to spend 45 minutes with a patient to try to figure out what their true problem is, probably get paid $15. It's a completely irrational system.
We don't have a healthcare system in this country. We have a disease management system.
We're spending almost twice as much in America as any other country on earth, but our lifespan isn't even in the top 20.
30,000 Medicare recipients die each year from care they didn't need. That's the equivalent of a jumbo jet crashing every single week. If the aviation industry killed as many people, we'd be up in arms.
The administration pays you based on how many patients you see. All right, who's next? If you try and buck the system, someone says, what can we do to get your productivity up? I'm not interested in getting my productivity up. I'm interested in helping patients.
We're seeing the military just being a microcosm of the problems society's having.
Soldiers' use of prescription drugs has tripled in the past 5 years.
This medications I was on.
Only by accepting that the American healthcare system is badly broken will we be able to seek out the escape fires, the potential solutions. There are answers.
One company has figured out how to lower healthcare costs by more than 40%.
We provide incentives for people to engage in healthier behaviors.
The Army Surgeon General directed that we establish the Pain Management Task Force to take a look at alternatives to narcotics.
I was skeptical, so skeptical.
I've gotten a lot of inspiration, a different perspective. There's a different way of doing things that is possible.
If I think about what healthcare could be like, it would have a lot more care in it.
The healthcare system is unsustainable. We're really mortgaging the future. Not just the health of healthcare, we're talking about the health of the nation.
So this is a great learning opportunity for students, and I will tell you the things that they post after it are, I'm going to spend more time with my patient. I'm going to make sure they understand what they need to do. I'm going to teach them. It's a 90-minute movie and very, very worth the time that you invest into it. So we'll move now to teamwork and collaboration. So teamwork and collaboration is to achieve quality and patient outcomes by effectively communicating with nurses and interprofessional teams and having mutual respect and shared decision-making. So teams are very important to everything that we do, and we know that. But you need to have a team where people work together and regard each other, treat each other with respect. John Nance, who is always on the television whenever there is some kind of terrible aviation accident, he has written a lot of books about teamwork. He says teams provide a safety net. So an individual, no matter how professional or experienced, is never as reliable as a team. So Barry, if you can go out to this site with Lucian Leap. Lucian Leap, I'm going to show you this. He actually talks for 8 minutes in this video, but I'm going to show you the first 4 minutes. It's very impactful about medication errors and errors that we make and why we need teams.
Like most doctors, I recall every one of them vividly, the serious ones. You never forget them. I mean, I've been out of practice for 22 years, but I clearly remember the serious mistakes I made. I didn't make a whole lot of them, but you remember them. One that would be helpful to talk about, I think, was I was a pediatric surgeon, so I operated on children. And one of the serious mistakes I made was failing to operate on a child who had bleeding from the intestinal tract. I delayed surgery so long that she ended up dying from this. And as far as I was concerned, it was entirely a judgmental error on my part. The teaching and my experience, I was fairly experienced at that time, been out of residency for 10 years or more. The teaching in my experience was that bleeding from the stomach in children always stops. You don't need to operate on them. And in fact, there was a fair amount in the literature about how it was wrong to operate on these people because you didn't need to. And so I believed that. And so we treated the child and gave transfusions and so forth, and finally became apparent that it wasn't stopping. And by that time, there had been enough damage that we weren't able to save her. I, of course, was devastated by this, as was the family. And we all cried together. I mean, no question about it. And I did explain it to him, and I apologized and so forth. But no apology is going to bring back your child. And I just thought it was about the worst thing I'd ever done in my life. What do you learn from it? Well, I think there's a very simple lesson, and that is decisions that are really critical to life and death or near that should never be made by one person. If we worked in meaningful teams, I wouldn't have been able to get away with that. I would have had people challenge. Nobody challenged my judgment. No resident or other person around ever asked any questions about it because it was my decision, and I was respected, and so it wasn't challenged. It should have been challenged. It should have been challenged. It should have been discussed in a open manner. And if we'd have had another pair of eyes looking at that child, she might be alive today.
I show that in my classroom, and I make it clear to students that there's a very respected man, Harvard Medical School. This is something that he talks about happening 50 years ago. It's still happening today, that people make decisions without consulting the team and without talking. And I tell them, you are a voice, so you need to speak up and take a chance. If you think that something is wrong and make your voice heard, be part of a meaningful team. So I think that gives them a good idea of even a well-respected man seeing how important it is. So this whole idea of speaking up, we really need to help students understand how to do that. The synergistic effect of having collaboration between all the disciplines is so good for the patient. They need to have system-based solutions for safe handoffs so that you can speak to another person and tell them what needs to be done and not worry about whether they're judging what you haven't done. We need to acknowledge everybody's contribution. The dietitian brings something, the housekeeper brings something, the pharmacist brings something. Everybody is bringing something that's so important, so acknowledge the expertise of all people. We tell our students that you need to speak up, advocate, 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 but we cannot send them out there without a tool to do it. So a great tool for them to assert and speak up is CUSS. It is an acronym for the words, I'm concerned, I'm uncomfortable, I don't think this is safe. So CUS. I tell my students you can cuss all day in clinical, which they do anyway, right? So here you go. So an example would be, Dr. Smith, I'm concerned with this vancomycin order. I'm uncomfortable because the patient's creatinine is 1.4. I don't think it's safe to give it. Oh, I didn't know it was 1.4. Okay, that kind of thing. So speak up. How about the 2-challenge rule? I tell students, just because you tell somebody something is wrong, if they don't do anything about it, then they haven't heard you. And you have an obligation as a nurse to say it again and again and again. And this is what we need to do in practice. I know as an ICU nurse for many years, you could say something and people just ignore it like it was not important. You have an obligation to challenge it again and again. We say 2-challenge, but it might be 4-challenge before someone hears it. How about the idea of critical language? The literature says that in the OR, that is the most difficult place to communicate, and that people are most afraid to speak up there because it is behind closed doors and there are no patients. So how do you speak up to somebody who in the chain is way up here and you're way down here? Critical language like, I need some clarity, stops it. So when you see a surgeon who is doing surgery on the right arm instead of the left, and you want to stop it before the cut is made, you would say, I need some clarity. And then everybody needs to stop and review what it is that you're doing. We think that we have wrong site surgery licked. We absolutely do not. Last year, 1,600 wrong site surgeries in the United States. So all the things that we're doing has decreased it, but we still don't have it stopped. So we need to teach students. You could do this at a bedside. Somebody's giving a transfusion or starting a transfusion for somebody that they shouldn't be, but it's the charge nurse and you're a new nurse and you're uncomfortable. I need some clarity. We are supposed to be giving packed red blood cells to so-and-so, in bed so-and-so, and help everybody to stop what they're doing and think about what it is we're doing so that they can correct themselves before they make an error. We need to have uniformed communication. So SBAR is a great framework. It came from aviation. Many hospitals are using it in practice. We need to make sure all our students are doing it. So one of the ways that you can do that is make them SBAR report in the classroom. I keep a telephone in the classroom. Occasionally, they have to call the physician with a problem. So if we were doing pulmonary edema, Dr. Smith, I'm calling about Mrs. Jones in 304. She is your patient. You admitted in pulmonary edema yesterday, and we've been managing her on 6 liters and 40 milligrams of Lasix IV push twice a day. This morning I came in, she's got crackles up 2/3 of her back, her respiratory rate's 32, and her pulse ox is 90. I think she needs more Lasix. And let them practice how to do an SBAR communication. I make them hand off to different places as you move your patient through different areas of the hospital. Hand off and use SBAR and make them run through it. So think about leadership. Things that we can teach them in a leadership course. There should be a pre-briefing. Anybody can be the pre-briefer. It can be the person who's taking care of the patient. Think about that. When a patient codes, doesn't the nurse caring for the patient lay it out as people arrive? This is what is going on. This is the patient's problem, and this is what we're doing right now. Always should be a debriefing. Debriefing should follow events and really be focused on learning. And here's what I want to say to you about that. It's really about feedback. And we got to think, this is a whole other day of to talk about feedback. But in a nutshell, when we give feedback to people, it needs to be focused on objective things that can be measured and not just our opinion. For instance, Lisa, we were at the code. Your compressions really weren't effective. They were pretty weak. That's judgmental. But if I said, Lisa, when you were giving compressions, the doctor couldn't feel a femoral pulse. So I just think we need to all think about, you got to push down 1.5 inches. So it's an objective data. This is what happened. This is what I saw. But it always leads to a conversation about evidence-based practice. What should it be? So that way, Lisa doesn't feel inadequate. We're just reviewing. I couldn't feel your pulse. I couldn't feel the pulse. Now we have to change how we do this. Let's all think about it. One of the tools that you can use, can we go out to this, Barry, Team Steps? Is everyone familiar with Team Steps? So Team Steps is a long program. It's a 2-day, but I'm going to tell you, we're going to cut to the chase here. When you teach in the classroom or you're teaching in the hospital, you can load this link up onto your desktop. This gives you an opportunity to show all of these different safety strategies in little Vimeos. So wherever you're teaching about, you have the ER patient who comes in with chest pain and how the nurse manages that and gets the doctor's attention and all the safe handoff piece. You have a situation where the patient's an inpatient and gets confused, and the person who picks that up is the phlebotomist who reports that. But the videos always show it done really poorly, where the patient crumps, and then they show you the next where you use all these safety strategies and the patient does really well. So it's a great opportunity for our students to see the before and the after. If you can just click on here, Barry, because since we talked about CUS, and I'll just demonstrate how these Vimeos come up, and you can make them full screen and just drop them into your presentations. Or so just scroll up a little bit and the picture should come up. Download failed. Okay, well, you know, it is what it is today. We can skip out of here. But it comes up as a small screen. You can enlarge it, and it's just seeing that safety strategy in effect. Other things that are on here, labor and delivery, a patient with a C-section who needs to go emergently, and that's a before and after where you see really poor communication and better. And then the out in the community, giving feedback when somebody falls through the cracks, and somebody who gives feedback really poorly and in an angry state, and then somebody who gives it much better. So Team Steps is a great tool. All of that is free for you too. So a couple of things to talk about that are up on the CUSUM website. We have giving and receiving constructive feedback. This is an important thing for all of us to learn. And as a faculty member, I will tell you, it's easy to get angry and to get upset, especially when you have 8 students out on the clinical floor and you're really pressed. We really need to think about the way that we talk to students, and we need to have them think about, when we talk to them, what is our motivation? In studying this whole thing with students and nurses, I have come to find out that when people get feedback, they really feel that you're offending them. And a lot of times it's a trigger for incivility. So we really need to think about how we deliver it, which I don't want to go into a lot of detail with that today, but this is a teaching strategy that's up on the CUSUM site. It's an 18-minute presentation that's narrated. I have my students, in fact, next Monday, first day of class, they have to watch this at home, and they have to post on the discussion board a significant idea. And what it talks about is how you should view feedback as an opportunity to improve. It's a chance to get better at what I'm doing and how important that is for patient safety and to make me a better nurse. And most of them, when they post, that's what they write. I used to get really mad at feedback, but now I'm going to think about this differently. By the time I get through them, they've been through fundamentals and mother-baby, and they've already got that attitude like the teacher wants me out of here. And it kind of changes the way it is. Another way to start that, I heard Susan Luperell speak, and she's wonderful. She said on the first day of class, just say, all right, who in here wants to be mediocre? Who wants to be mediocre? And of course, no one raises their hand, and she says, okay, so if you don't want to be mediocre, you want me to give you feedback, is that it? And everyone smiles. They get it. Like, that's the idea. That's the only way that you become better. This down here is all the difficult communications our students are going to come in contact with, and our nurses do come in contact with. I will tell you that I did this one with nurses. They wrote great stories. In the OR, where they told doctors the count was off, and the doctor said, I took one sponge in, I took one sponge out, that's the end of it. Close the patient up. 2 days later, fully infected. So students, I show them, I'd have them write about an instance where they saw communication be a problem, put a patient at risk. Then we run through all the slides, which when you go to these CUSIN teaching strategies, all the slides and everything you need is there. We run through the slides to teach them how to communicate when there's a problem. And then I have them reframe their story and retell it. I could have cussed at him. I could have done a 2-challenge rule. Those kind of things to try to fix it. If we can go out to here, Barry, and hopefully this will show up in leadership class, we tell students to be leaders. How about if we tell them be followers? Get on board with quality and safety education and all the things that go with being a safe practitioner. I'm going to show you just a short video that entertains them, but certainly teaches them how important it is.
If you've learned a lot about leadership and making a movement, then let's watch a movement happen start to finish in under 3 minutes and dissect some lessons. First, of course, a leader needs the guts to stand alone and look ridiculous. But what he's doing is so simple, it's almost instructional. This is key. You must be easy to follow. Now here comes the first follower with a crucial role. He publicly shows everyone else how to follow. Notice how the leader embraces him as an equal. So it's not about the leader anymore, it's about them, plural. Notice how he's calling to his friends to join in. So it takes guts to be a first follower. You stand out and you brave ridicule yourself. Being a first follower is an underappreciated form of leadership. The first follower transforms a lone nut into a leader. If the leader is the flint, the first follower is the spark that really makes the fire. Now here's the second follower. This is a turning point. It's proof the first has done well. Now it's not a lone nut and it's not 2 nuts. 3 is a crowd and a crowd is news. A movement must be public. Make sure outsiders see more than just the leader. Everyone needs to see the followers because new followers emulate followers, not the leader. Now here come 2 more people, then 3 more immediately. Now we've got momentum. This is the tipping point and now we have a movement. As more people jump in, it's no longer risky. If they were on the fence before, there's no reason not to join in now. They won't stand out, they won't be ridiculed, and they will be part of the in crowd if they hurry. And over the next minute you'll see the rest who prefer to stay part of the crowd, because eventually they'd be ridiculed for not joining. And ladies and gentlemen, that is how a movement is made. So let's recap what we've learned. If you are a version of the shirtless dancing guy, all alone, remember the importance of nurturing your first few followers as equals, making everything clearly about the movement, not you. Be public, be easy to follow. But the biggest lesson here, did you catch it? Leadership is overglorified. Yes, it started with the shirtless guy, and he'll get all the credit, but you saw what really happened. It was the first follower that transformed a lone nut into a leader. There's no movement without the first follower. See, we're told that we all need to be leaders, but that would be really ineffective. The best way to make a movement, if you really care, is to courageously follow and show others how to follow. When you find a lone nut doing something great, have the guts to be the first person to stand up and join in.
Here's what I'll tell you about that. If you are the lone nut at your school trying to put CUSIN in place, just keep pushing and pushing gently and get people to come on board piece by piece, and you'll see that it will spread. I think it's a good lesson for our students to learn that they need to be followers, and they need to, not always be followers, but they need to think about when they find something good, get on board with it. So this next thing I want to show you, we'll do this and then we'll take a break, I think this is the end of the teamwork piece anyway. Can my 4 volunteers come on up? These are my colleagues at Einstein, so I asked them to be our volunteers today. I would like to show you what a healthy team looks like. I go to summer camp every year for health professions educators. We learn lots of good stuff, so this is something that I learned there. All right, so we think about teams, and we think everybody's got to get along, and everybody's got to work together, and we see that person who's always difficult and think, why are they on our team? But I want to tell you that everybody needs to be there to make a good team. All right, Lorraine, come on, you're here. This is Lorraine. Lorraine's job, you're the mover. You're shaking it up. I want you to stand like this. You go, girl. All right. So Lorraine is the mover. She makes things happen. She brings all the ideas. Denise, you're the supporter. Get in there and support Lorraine. However you, no, right here, support her. Oh, wow, that's very nursing and caring. All right, support her however you want to support her. So everybody who's moving it needs to have somebody who's supporting the work because they go, yeah, that's a great idea. Come on, Sue, you're the role we hate. All right, I want you to stand here like this. Guess what her role is? You know, she's the resistor, all right? So you got the mover, the supporter, the resistor. Priscilla, come here. Priscilla's job. Good job, Priscilla. You're just standing there doing nothing. We always have somebody on the team who looks like they're standing there doing nothing, right? But here's the thing. You need the standing there doing nothing. You know what they're doing? She's the observer. She's going to give feedback. You know why? Because she's not bought into this one. She's not bought into this one. She's not bought into this one. So she can give effective feedback to this, this, and this. So you need all of these people. Otherwise, your I's don't get dotted, your T's don't get crossed. This person, but what about, but how about, but what if? You need that person so that you prepare for all of that stuff. So this is actually what an effective team looks like. Thank you very much, ladies.